Menstrual Cycle and Reproductive System. Introduction to the module. The foundation for understanding fertility, including the process of contraception, is knowledge of monthly physiology. It serves as the basis for natural family planning. Menstruation is one part of a woman's cycle when the lining of the uterus, endometrium, is shed. This occurs throughout a woman's reproductive life. With each monthly cycle, the endometrium prepares itself to nourish a fetus. This module will teach us about the menstrual cycle and reproductive system. Learning objectives. At the end of this module, you will be able to discuss the menstrual cycle, identify premenstrual syndrome, describe the female reproductivity system, explain subfertility and birth control methods. Menstrual cycle. The lining of your uterus sheds each month during menstruation. Menstruation is sometimes referred to as menses, a period, a cycle, or a time. The menstrual blood leaves your uterus through your cervix and exits your body through your vagina. Menstrual blood is partially blood and partially tissue from the interior of your uterus. The sequence of events within your body as it gets ready each month for the potential of pregnancy is known as the menstrual cycle. The first day of a period is regarded as the start of a menstrual cycle. The cycle duration can vary from 21 to around 35 days, with the typical cycle lasting 28 days. The menstrual cycle involves four main hormones, substances that either stimulate or regulate the functioning of cells or organs. Among these hormones are follicle-stimulating hormone, luteinizing hormone, estrogen, progesterone, hormonal control of ovulation. The hypothalamic pituitary axis regulates the menstrual cycle. The pituitary is a tiny, cherry-sized gland located behind the bridge of the nose near the base of the brain. Gonadotrophin-releasing hormone, GnRH, a decapeptide, activates it, a hormone of 10 amino acids. Pulsatile venous channels allow the hypothalamus to release GnRH into the body. The frequency and amplitude of these pulses determine the pituitary gland's reaction. The anterior pituitary gland secretes the hormone called follicle-stimulating hormone, FSH, which activates the Graafian follicles. In contrast to the luteal phase, FSH levels are higher in the early follicular phase of the menstrual cycle, initial follicular development. Just before ovulation, it exhibits a minor surge that coincides with the important peak of the luteinizing hormone, LH. Aside from the LH peak, the anterior pituitary also secretes LH, which is basal throughout the cycle. The LH peak starts about 36 hours before ovulation and lasts for 24 hours, with the peak taking place 24 hours before ovulation. Development of the Graafian follicle. From day 1 of the cycle forward, the granulosa cells of the follicles begin to emit the hormone estrogen as the follicles begin to grow. Estrogen influences several bodily functions in addition to controlling gonadotrophin secretion. A single follicle typically matures as the level of estrogen increases due to decreased FSH release. Different follicles respond differently to FSH, and the one that responds most quickly becomes dominant and is the one that will ovulate. There is atresia in the other growing follicles. The ovary also secretes the hormone inhibin, type A and type B, and both have an inhibitory effect on the pituitary regarding FSH. Premenstrual syndrome. The physical and psychological symptoms that women go through in the week or two before their period are referred to as premenstrual syndrome or PMS. The typical PMS symptoms are mood swings, bloating, cramps, and headaches. These symptoms may only be a slight annoyance to some people. The exact causes of PMS are still a mystery. However, the symptoms are probably brought on by regular changes in hormone levels, particularly estrogen and progesterone, in the week or so before menstruation. After ovulation, estrogen and progesterone levels sharply decline. This might significantly contribute to the emergence of PMS symptoms. Serotonin levels may change as a result of the decline in estrogen levels. A brain chemical called serotonin helps control mood, sleep, and appetite, all of which are impacted by PMS. It is uncommon to experience severe or incapacitating PMS symptoms, and these symptoms may be a sign of an underlying medical illness. Any severe PMS symptoms should be discussed with a doctor. PMS physical signs can include changes in appetite, including food cravings, swelling or painful breasts, abdominal bloating due to weight increase, lower abdominal discomfort or menstrual cramps, cramping or diarrhea, headaches, fatigue, acne, pimples, and other skin conditions with oily skin. PMS can cause psychological symptoms such as low mood, sobbing or feeling tearful, irritated, or raft depression, elevated anxiety, mood changes, issues with social disengagement, such as insomnia, sleep, having trouble concentrating, reduced desire. People who have PMS may also observe worsening signs of diseases like diabetes, depression, and inflammatory bowel syndrome. What happens during the menstrual cycle? Hormonal cycles occur in females of reproductive age, between the ages of 11 and 16, and they repeat roughly every month. The menstrual cycle is derived from the word menstru, which means monthly. Whether or not a woman intends to become pregnant, her body prepares for one with each cycle. The average menstrual cycle takes about 28 days and occurs in phases. These phases include the follicular phase, development of the egg; the ovulatory phase, release of the egg; the luteal phase, hormone levels decrease if the egg does not implant; follicular phase. On the first day of your period, this phase begins. The following things occur during the menstrual cycle's follicular phase. 1. The brain releases two hormones, follicle-stimulating hormone, FSH, and luteinizing hormone, LH, which go through the blood to the ovaries. 2. The hormones promote the development of 15 to 20 eggs in the ovaries, each in its own shell, called a follicle. 3. Additionally, the female hormone estrogen is produced more frequently due to these hormones, FSH and LH. 4. Follicle-stimulating hormone production is switched off as estrogen levels rise. The body may control the number of follicles that will mature eggs for a release by carefully balancing its hormone levels. 5. One follicle in one ovary becomes dominant as the follicular phase develops and continues to mature. All other follicles in the group are suppressed by one dominating follicle. They consequently stop developing and pass away. Estrogen continues to be produced by the dominant follicle. Ovulatory phase. Ovulation typically begins approximately 14 days after the follicular period, though this might vary between the follicular phase and the luteal phase, the ovulatory phase. 10 to 16 days following ovulation, most women will begin to menstruate. The following things take place during this stage. 1. The increase in estrogen released by the dominant follicle causes the brain's production of luteinizing hormone to increase. 2. The dominant follicle then extrudes its egg from the ovary as a result. 3. Finger-like projections on the end of the fallopian tubes catch the egg as it is released, a process known as ovulation, fimbriae. The egg is swept into the tube by the fimbriae. 4. Many women have an increase in cervical mucus composed of egg whites 1 to 5 days before ovulation. This mucus, which results from vaginal discharge, aids in sperm catch and nutrition as it travels to the egg to fertilize it. Luteal phase. Following ovulation, the luteal phase begins and entails the following activities. 1. The empty ovarian follicle transforms into a brand new structure known as the corpus luteum after it releases its egg. 2. The corpus luteum secretes the hormones progesterone and estrogen. Progesterone makes the uterus ready for a fertilized egg to implant. 3. The fertilized egg, embryo, which results from sexual activity and a man's sperm fertilizing the egg, a process known as conception, will pass through the fallopian tube and implant in the uterus. Now, the woman is seen as pregnant. 4. The egg goes through the uterus even if it is not fertilized. The uterine lining disintegrates and sheds when it is no longer required to support a pregnancy, and the subsequent menstrual cycle starts. Female reproductive system. The female reproductive system serves several purposes. The egg cells, also known as ova or oocytes, are made in the ovaries. The oocytes are subsequently sent to the fallopian tube, where sperm fertilization can take place. The fertilized egg is received in the uterus, where the process continues because the uterine lining has formed there in response to the normal hormones of the reproductive cycle. The fertilized egg can implant into the thicker uterine lining once inside the uterus and grow there. In the absence of implantation, menstrual flow sheds the uterine lining. The female reproductive system also creates female sex hormones, which keep the reproductive cycle in check. The female reproductive system gradually stops producing the hormones required for the reproductive cycle to function throughout menopause. Menstrual cycles may now start to fluctuate and eventually end. The woman is regarded as menopausal 1 year after her periods stop. Both exterior and internal structures make up the female reproductive anatomy. The exterior female reproductive structures, or genitalia, have two purposes. To allow sperm to enter the body. To shield the interior genital organs from pathogenic germs. Subfertility. Subfertility is the inability to conceive after a year of repeated unprotected coitus. Even though this incident did not result in a live birth, such as a miscarriage or an ectopic pregnancy, a woman who has never conceived has primary subfertility. In contrast, a woman who has conceived before has secondary subfertility. Causes of infertility. Fallopian tubes, an infection may partially or completely block them. Ovarian dysfunction. Ovulation may not occur. Ovulation is irregular within ovulatory cycles. Polycystic ovary syndrome. Hyperprolactinemia. Perimenopausal. Premature ovarian failure. An intact hymen. When a marriage has not yet been legally consummated, a woman may complain of infertility. Vagina, congenital malformation. Uterus, congenital malformation or tuberculous endometritis. Treatment of subfertility. A couple seeking medical help for subfertility is undoubtedly worried and anxious. Even if the subfertility stage is only a short while, they should always be offered assistance. After a year of attempts, investigation should be conducted on the majority of couples. About 25 to 30% of women who seek help for subfertility become pregnant while receiving testing and care. There are numerous therapy options which, depending on the condition identified, might be effective. 1. Correction of coital difficulties. A healthy hymen should be extended or eliminated. It may be necessary to remove a vaginal septum, but this rarely presents a significant challenge. Teaching the woman how to pass vaginal dilators is important because doing so boosts her confidence. Coitus is made easier by the use of lubricant. The most frequent issues with male fertility are early ejaculation and insufficient erection. 2. Lesions of the uterine body. Small uterine polyps removed via curettage are frequently effective. The fallopian tubes should be removed if the fibroids are submucous or obstructing them. Other disorders, such as endometriosis or peritubular adhesions, which call for appropriate treatment, may be discovered during a laparoscopy or laparotomy. A laparoscopy or laparotomy may reveal additional conditions that require treatment, such as endometriosis or peritubular adhesions. Birth control methods. To avoid pregnancy while allowing for continued sexual activity, one uses contraception. The ideal contraceptive should be risk-free, perfectly harmless, and should not obstruct either party's ability to enjoy sexual activity. Differentiate between population control and family planning. Family planning is a sensitive topic that requires a low failure rate. Population control, where the requirement for affordability and simplicity may allow acceptance of a less stringent threshold of efficacy. Methods used by the female. Hormonal. 1. The pill, combined oral contraceptive, estrogen and progestogen. 2. The emergency pill, high-dose progestogen. 3. The mini pill, progestogen-only pills. 4. Injectable hormones, progestogens. 5. Implantable hormones, progestogens. Intrauterine contraceptive devices, IUCDs. 1. Copper-bearing devices. 2. Progestogen-bearing devices. Barriers. 1. Diaphragm or Dutch cap. 2. Cervical cap. 3. Vault pessary. 4. Vaginal sheath. Chemical spermicides. 1. Soluble pessaries. 2. Creams, foams and jellies. 3. Medicated sponges. 4. Douching. Highlights from this module. Subfertility is the inability to conceive after a year of repeated unprotected coitus. During menopause, the female reproductive system gradually reduces the hormone production needed for the reproductive cycle to continue. The female reproductive system gradually stops producing the hormones required for the reproductive cycle to function throughout menopause. PMS is the term used to describe the physical and emotional symptoms that women experience in the 2 to 3 weeks before their menstruation. Menstrual blood is partially blood and partially tissue from the interior of your uterus. Thank you. This module has ended. Hope that you have learned something valuable.